Thanks again, Dr. Andrew Wright, for talking to the op report. Let's talk about closing the abdominal wall and bite size and suture length.
Perfect.
What have we learned about the tendency to form hernias and what we should keep in mind when closing the abdominal wall?
So I think the first thing is that most general surgeons don't recognize how prevalent hernias are. And anytime we do an abdominal incision, the expected rate of hernia formation is 20 to 30%. A lot of that driven by our obesity epidemic. So I think a lot of us as surgeons, we kind of think about abdominal closure as the end of the case. We started to check out mentally, started to think about what we have to do next. And I really think it just drives home the importance of really paying attention and focusing on the closure is just as important as the bowel anastomosis or any other part of the operation.
Yeah, some might even leave the room at that point.
Yes,
in
I
teaching
certainly spent a
institution.
lot of time as a junior resident, a mid-level resident, closing the fascia, closing the skin with no supervision. And I think in the modern era, that's really not appropriate
Yeah,
anymore.
yeah. So what was different when you were training and what has been learned about suture length and bite size?
Sure. So I think it's been fairly well established for a long time that a slowly absorbable running suture is the best closure. And that data has been around since the 70s or 80s. I know some of my trauma colleagues still don't believe it, but that's actually pretty well accepted. What's new is this concept of a small bite and a longer stitch to suture or stitch to wound length ratio. And the idea is that in the past we were taught, or at least I was taught, to take 1 centimeter bites back on the fascia and bites that are 1 centimeter apart. And the idea is you catch a big bite and it's going to be really strong and meaty. I learned using the Lute O Maxon or O PDS suture, which is a big needle and big suture. And it turns out that actually that probably increases your hernia formation rate compared to much smaller bites, smaller needle, smaller suture size. The best data comes out of Europe. There's a gentleman there, Israelson, who's really been a pioneer in studying how hernias form and what we can do to prevent them. And their group has shown very conclusively that a small bite, meaning 5 millimeters on a 5 millimeter bite instead of 1 centimeter bite, and placing those bites 5 millimeters apart dramatically reduces the hernia risk. On the order of cutting it close to half at 1 year.
Wow. So can you explain that suture to wound length ratio?
Yeah, so basically when you have, say you have a 10 centimeter wound, just to make it simple, if you use a 20 centimeters of suture to close that, you have a 2-to-1 ratio of the suture length to the wound. If you use 40 centimeters of suture length, then you have a 4-to-1 ratio. And the idea is that the longer the suture ratio, so the more suture you use, the lower your hernia rate. And you're essentially offloading the stress or the strain on more suture and therefore decreasing the tension on any one point in the closure. From a physics perspective, it's like using a zipper instead of buttons. Each individual hook of the zipper may not be very strong and it may be very small, but because you have many of them, you're much less likely for that to fail than if you have just a few points of fixation along the length.
Yeah. So tell me about the size of the needle and size of the suture.
Sure. So we obviously learned to use this big needle and big suture, and the idea is it was nice and strong to hold the tension. But the problem is that needle is so big and the suture is so big that it actually tears through the fascia, and especially if your bites are big and going through the muscle, it's going to tear through the muscle as well, and that's going to create little Swiss cheese defects that we often see at the time of a hernia repair. So one of the other innovations that the group in the Netherlands came up with is using a smaller needle. So they use a small needle and they use 2O, a slowly absorbable suture. I like Maxon, but PDS would be the equivalent from another company. And the idea is that the 2O is strong enough to hold the abdominal wall, but it's also small enough that it's not tearing through the fascia as much. And you're using it on a smaller needle. The other nice thing about the small needle is that it allows you to take those nice small bites. If you have a big needle, it's really hard to take a 5 millimeter bite. That needle just cries out for a big honking bite through everything. So I've personally switched to using the 2.0 absorbable suture on pretty much all of my closures. Every once in a while, when I'm doing like a recurrent incisional hernia where it's a lot of scar and just a lot of junk, I'll take bigger bites just because the nature of the tissue. But certainly for a primary closure or a first time operation, I'm doing the small bites and I'm using that small needle with the 2.0 suture.
Mm-hmm. I'm curious, do you ever put a mesh in for a primary closure first time abdominal operation?
Personally, I don't. It's interesting you ask that because there's actually growing data that suggests that that's probably a good idea in selected patient populations. The same group in the Netherlands have just published a study looking at mesh for vasculopaths. And as you may know, folks who are getting an open AAA repair are actually amongst the highest rate of hernia formation. Probably something having to do with their collagen formation. And the same reason they get an aneurysm is the same reason they get hernias. But they randomize patients to getting mesh versus no mesh for primary repair, and they just use a small strip. I think if I remember this paper correctly, it's like a 2 centimeter strip of mesh that they run right down as an onlay and incorporate that in with their closure. And that's dramatically reduced their risk of hernia in that patient population.
So I don't onlay on the external surface of the closure.
Exactly. Yep, on the outside, because they're trying to avoid placing mesh intra-abdominally in that setting.
Yeah, I've heard of some people also using mesh primarily for first-time stoma creation.
Yeah, it's interesting. You have to be careful with that. We can talk about it, but the FDA recently pulled approval for stoma mesh from believe every company because they decided that there wasn't enough data to support its use.
Oh, interesting.
So companies can still market mesh for abdominal wall reinforcement, but they can't market it now for stoma reinforcement. That being said, a lot of people use it, and I certainly use it in patients with a peristomal hernia.
Mm-hmm. How about, I recall having some attendings who insisted on closure with interrupted suture for their, sometimes for reoperations. And, well, if you run it and you pop that one stitch, then the whole abdomen falls apart. What's the theory there?
Yeah, and I've certainly heard that. And when I say kind of jokingly, some of my colleagues in my own institution haven't adopted a small bite running technique, it's actually a lot of the trauma folks. It's the folks who are doing kind of the acute care surgery emergency, middle of the night kind of stuff, because they're worried about the whole abdomen dehiscing. The idea, though, is if you have an interrupted suture, you basically have a tourniquet. And as the tissue swells, that suture is actually cutting through. And especially if you tie that suture pretty tight, it can actually cut through and dehiss. So there's data, very good data, that suggests that the running closure is better than interrupted and actually has a lower dehiscence and a lower hernia rate. Not everybody goes along with that. I think if you're really wedded to the idea of an interrupted, I would at least run and then maybe place a couple of interrupted figure 8 sutures just as sort of backstops. But I think your primary closure should still be a running closure.
Mm-hmm. Do you have an opinion on retention sutures?
Yeah, I haven't personally put in retention sutures since I was probably a third-year resident, so I'm not a big believer in them. I will say some of the criticisms of kind of the small bites technique, the European technique, is that patient population that those studies have been done in is all the European nice, thin, healthy, first-time surgery patients. It may not reflect the American population. And I think the average BMI in their series was 28, which my average BMI for patients is considerably higher than that. Yeah. So I think that is a legit criticism, and you could say maybe we need to repeat that randomized trial in the U.S. with our patient population, but in the absence of other evidence, I still think it's pretty compelling.
Sure, absolutely. Last thoughts on suture bite size and
techniques? So I think there are two other subtleties in the Israelson technique that I think we don't talk about a lot. besides, again, the size of the bites, the spacing of the bites. A couple of those are, one is you really want to avoid the muscle. And the idea is every stitch is in the linea alba. And if it's okay, I want to flip over to share my screen and show you a diagram of that. Let's see. See if I can get this to work here. So if you can see the screen here, is that showing up, Chris?
I've just got the spinning icon thing.
I can still see you.
That's funny. So I can see your mic. Oh, I can see it now. Okay.
All right. So this is this top diagram is sort of our classic American way of putting in a big stitch that goes through the fascia, catches some of the subcutaneous fat, and goes through the muscle. And over time, as the wound retracts, as you have tension on the wound, that suture actually starts to cut through the muscle. And if you're out here laterally, you actually have the anterior fascia, you have the posterior fascia. Those are thinner than the fascia at the linea alba in the middle. So the idea is that the small stitch technique, you're really just catching the fascia. You don't catch any of the subcutaneous fat. You don't catch any of the muscle. And just by getting the linea alba, you're not having that cutting through of the tissue. Mm-hmm. And you don't have the stretching. If you think about the amount of stretch you can get on a rubber band, a bigger rubber band's going to stretch wider, whereas a smaller rubber band doesn't stretch as wide because it's smaller as a proportion. So the other graph I just want to show real quick, and the reason I think it's more important to talk about the small bite technique than the wound length or suture length technique, is you can actually get a 4-to-1 ratio a couple different ways. So you can get a 4-to-1 ratio by taking lots of small bites. You can also get a 4-to-1 ratio by taking lots of really big bites.
Thanks again, Dr. Wright.
Oh, my pleasure.
Talk to you soon.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.